The following is a WDBJ7 special presentation.
Nearly 25% of Americans suffer with mental illness.
Where do you go for answers or for help for those in need? The following program, Stop the Stigma, provides insights into the warning signs, the struggles, and the programs available for mental illness.
Please watch to learn more about the current state of public mental health care and neuroscience research that will help patients in the future.
Underwriters of Stop the Stigma are Carilion Clinic and Lewis Gale Regional Health System.
Good evening, everyone. I'm Chris Hurst. For the past 4 months, I've jumped into the vast ocean that is Virginia's public mental health care system, trying to figure out how efficient we are at getting lasting treatment to those who need it. The reason this odyssey started is clear. Bath County State Senator Creed Eads has become the face of potential mental health reform after it was forever scarred by his son. Gus Deeds was not held up by our public mental health safety net and is now a case study in the gaps of how our local community services boards are able to help those in crisis. But Senator Deeds is not the only face of mental illness. Tonight, it's our goal to show you the other faces. The face of a mother and daughter impacted by bipolar disorder and currently in jail after her unheard threats to hurt someone she loved were realized. The face of a father, brother, and son suffering from alcoholism and depression who killed himself after a chaotic breakup from his wife. And the faces of a mother and her son, both coping with mental illness and trying to find understanding from a community that doesn't always know how to interact with them. Over the next half hour, it is our hope we can illuminate some of the inconsistencies in our public mental health system, how this year's legislation may alleviate some problems and create new ones. We also want to showcase efforts to arm first responders to mental illness with the tools they need to treat everyone with compassion and respect. And we'll give you tips you can use starting tonight to better communicate with those who you know who might be suffering, as well as give everyone hope of a better possible diagnosis of mental illness by showcasing innovative research being done right here in Southwest Virginia. And through it all, we hope to contribute in any way we can to stop the stigma. Breaking the cycle of stigma is the key to unlocking lasting effective treatment. You reduce the stigma, more people will be willing to seek help. You reduce the stigma, possible funding will be created to improve care. You reduce the stigma, and we may finally be able to look at mental illness the same way we look at physical illness. But it won't be easy. Not when severe mental illness can lead to violence, as sometimes happens. That's when the state gets involved and can order someone into custody. Diabetes and heart disease in advanced stages don't usually pose a threat to our personal liberty. Schizophrenia and severe bipolar disorder can. And in severe cases, it can also threaten the lives of others. Do you still love her?
There are definitely some deep feelings there.
Even though she tried to kill you?
Yeah. Yep. Again, from my perspective, I know that there's a mental illness there. So just like you can love somebody that has some sort of terminal disease, I can love somebody that's got a mental illness that, yeah, it's hard to look past, you know, having your life threatened and then actually having somebody act on it. It's extremely surprising, but I still care for her.
Elizabeth Wright goes by her middle name, Caitlin. Her mother reached out to me and told me her story through email. She was 14 when she first tried to kill herself by swallowing a bottle of lithium pills she was prescribed for her bipolar disorder. For the next 10 years until today, she would be in and out of hospitals and police custody without ever finding suitable treatment. In describing a litany of traumatic experiences for Kate, her mother told me she tried to stab a police officer with his pen, tried to kill a lover with glass from a broken lamp, and would cope with heroin and alcohol. 8 months ago, she moved from Colorado to Virginia to be closer to her kids and lived with her boyfriend, Randy Plouffe, in Roanoke County. Without insurance and a way to pay for suitable medications, Randy says he took her to a doctor who gave her heavy tranquilizers and pain patches. Did the medication that she was provided, did it help her thrive, or did it basically just keep her docile?
It masked her symptoms, basically.
She wasn't living.
Right.
But when Kate met another man in her apartment complex who began to give her drugs and alcohol again, her violent behaviors returned. On Valentine's Day this year, she lashed out, threatened to kill herself, and when police arrived, she told Randy she would kill him.
Speaking to the officers, I said, you know, rather than taking her to jail for struggling with you guys, can you get her to a hospital?
That prompted a stay at a psychiatric bed facility. She was admitted because she posed a suitable threat to herself and others. But a few days later, she was released. 2 weeks after that, in early March, Randy says Kate and the other man tried to kill him.
And yeah, I was almost killed.
Giles County Delegate Joseph Yost spent years in the mental health field and is now an advocate for reform in the General Assembly. When it comes to people who enter into an inpatient facility and then they get released, are people getting released because they have been deemed healthy enough to be released to care?
It's been my experience, I don't think individuals are necessarily healthy enough to be released just yet. You know, when I look at the system as a whole, as over the last almost a decade now that I've been involved in it, you know, it seems like we just sort of filter people through.
In order to understand the gaps in how mental health care and treatment is given to those who need it most, you need to know how the system is set up. And providers admit it is incredibly complex to navigate. For nearly 100 years, Virginia housed mental illness patients in institutions that were even once called lunatic asylums. Then, in the mid-1960s, we decided it was best to return stable patients to their communities, who were best equipped to provide long-term care. Out of that, 40 community services boards were created in the Commonwealth, 12 of which serve the WDBJ7 viewing area. The term reflects not just the organization at large, but also the actual boards that have public members who help decide best practices. Aside from getting some funding and being licensed to provide care from the State Department of Behavioral Health and Developmental Services, each community services board has an incredible amount of autonomy on how to administer mental health care. Even the names aren't standard. Some call themselves community services boards. Others take off the board. Still others take the word community out entirely and call themselves behavioral health care. No matter the name, each CSB is tasked with being the conduit for those who seek treatment but can't afford private options by offering counseling and psychiatric services.
We do begin with breaking news this afternoon.
The other responsibility of a CSB is to respond to psychiatric emergencies that result in an order from a judge to place a patient into custody. First, an individual will be held by local law enforcement, so a screener provided by a CSB can do an initial evaluation. It's called an emergency custody order. If it's deemed necessary to hold a person longer to see if they can come out of crisis and respond to treatment, it's called a temporary detention order. But it's not always that simple. In November, Gus Deeds had a mental health crisis. A magistrate ordered an emergency custody order, and he was screened by his local CSB, the Rockbridge Area Community Services Board. It was determined he needed a temporary detention order as well, but his CSB could not find a willing facility with a psychiatric bed. It was revealed late last week the screener who met with the Deeds family didn't even show up to Bath Community Hospital until time almost ran out. And the screener told the Inspector General's office he called 10 different places for a bed, but a report revealed no record of any more than 7 places contacted. Often a bed can be found the next morning, but in this case, Gus went home, attacked his father, Bath County Senator Cree Deeds, and then killed himself. When a patient is under an ECO and temporary detention is advised, but the person is let go because no psychiatric bed can be found, it's called streeting. 2 years ago, the Inspector General for the department issued a report that foreshadowed what happened to the Deeds family. Over a 3-month period, 72 people were streeted across Virginia, about 1.5% of the time. 2 main reasons stick out as to why people who need a psychiatric bed for intensive care don't get one. CSBs in general didn't contact every place that could have had an available bed, and that both state-run and private psychiatric bed facilities can't or won't accept the patient. We're here at Catawba Hospital, one of 16 state-run inpatient psychiatric bed facilities. It's mental health hospitals like this one that were cited extensively in the Streeting report as places CSBs sometimes didn't even contact and often are at or beyond their capacity to accept new patients. After the Deeds case, lawmakers came together to try to make the system more efficient so that streeting is an even rarer occurrence than it already is. Senate Bill 260, introduced by Cree Deeds, includes lots of other bills and would allow for more time for a bed to be found, from 4 hours to 8, with 2 possible 2-hour extensions. It would fund an online psychiatric bed registry, which is now live and is used by CSBs across the Commonwealth. And it would create a better safety net by requiring state-run facilities to be a bed of last resort. And most importantly, stakeholders tell me, is that it would create a 4-year comprehensive study of our public mental health system to find issues in the future and then address them.
We're creating a different problem.
But not every lawmaker supported the changes when first proposed. Grayson County Senator Bill Carrico is a former state trooper and initially voted against many of the proposals, citing an increased burden on law enforcement.
There's a lot of waiting, and that law enforcement officer cannot leave that individual's side while that waiting occurs.
There's a lot of pressure when we are in that emergency custody order process and trying to find folks treatment and get them to the appropriate level of care, knowing that we have to go through a medical evaluation process and that beds may not be readily available locally.
At Lewis Gale Montgomery Hospital, tucked in the back, are 3 small rooms operated by New River Valley Community Services. It's called a Crisis Assessment Center, a quiet place for the ECO process to take place. But what really helps officers and deputies is the ability for them to come, drop off an individual, and have a legitimate transfer of custody.
If we were not using this facility and we were not able to transfer custody of somebody, that certainly becomes a manpower issue at that point.
But there's not one of these drop-off centers in every community. The next closest one to this one in Blacksburg is in Martinsville. There is money allocated in the still yet to be adopted state budget to create more in the next year. But Senator Carrico worries his area won't get one.
In Richmond, the more affluent, largely represented areas are usually the ones that get them.
And here's another problem to consider. Let's say a bed is found and you are getting treatment even after your TDO expires because you need long-term consistent care. The goal is still to get individuals back to their community and out of hospitals like this one at Catawba. But it's not always that simple. Some patients inside are deemed ready to be released, but can't because their community can't offer them the same level of care. And the same goes for private psychiatric bed facilities. It then creates a turnstile effect where those who are not in extreme distress are admitted, stay a few days, and then are released. But just because you're released doesn't mean your mental health needs are being met.
The last time I saw him, he was laying in a hospital bed and he just had his stomach pump. And that was on a Friday and they let him out that Monday. So,
do you consider that treatment?
No, I consider that just, pushing him out the door. Dwayne
Price is talking about his brother Todd. Struggling with alcohol addiction, Todd went into a deep depression last fall after his breakup from his wife. He tried to overdose on morphine pills twice and was admitted to a private psychiatric facility each time. His stays were short, and his family says he wasn't given any plan for continuous treatment. Then in early January, he replaced pills with a gun and killed himself.
There ought to be more stringent guidelines of how you treat someone after they've tried to kill themselves, and obviously they're serious about it. And I don't think you can get that done in 3 days.
We're joined now by Kate's mom, Sherry Woody. Sherry, thank you very much for joining us today. First, tell me, Kate was arrested on attempted murder charges. She's in Western Virginia Regional Jail. Have you been able to speak with her, and what is she saying?
I was able to speak with her the day after she was transferred to the Western Virginia. And it was for a matter of 2 minutes, and she just said to me, "Mom, please just do something."
So let's talk about this. When it comes to doing something, how difficult has your family found it to get something done for suitable treatment for her mental illness?
Well, Caitlin started displaying symptoms at a very young age, at 12 years old, and then at 14 when she had her first suicide attempt, and she had taken a whole bottle of lithium and ended up with an enlarged heart and went into kidney failure. So at that time they put her in, at that time we were in Tennessee, they put her in Peninsula Hospital. She was there, they put her in outpatient care, and then she was deemed to return back to school. And one thing that happened with Caitlin is that she could not be around other students. So when she was around other students, it caused a lot of anxiety. So it struggles with the school system in order to be able to get her classified as a disability, as a mental illness.
Caused in part, you think, by overall stigma, by people not wanting to be engaged with her, to be in a situation with her because they were afraid?
They were afraid, and now she was labeled as that girl who tried to kill herself. And Caitlin...
How does she live with that for her life, with that label?
Well, she lived with it by self-medicating. After that time, we ended up getting her out of school. She was homeschooled, and she ended up getting her GED. But then as the illness progressed, we tried to get her help, but she continued to mask it with the drugs and the alcohol, and that became part of her life in order to mask the symptoms. And then when she became 18, I no longer was able to intervene.
You have told me that since she's been in jail, you are now grieving the loss of your child. Explain what you mean by that.
I feel I've lost her because the night that I got the call that Caitlin was being charged with attempted murder and with kidnapping, the dreams that you have for your child growing up is of a little girl getting married, having a family of her own, and she lost that dream. And I look at Caitlin and I see that she's no longer going to have that dream if she is incarcerated for the 20 years that they're anticipating that she could be incarcerated for. There is no, at a level of the community, there's no way to convey to, whether it's church or family or with mental illness, there's such a stigma behind it that when you go to someone and say, I am hurting and grieving the loss of my child because they're incarcerated, it's not the same as grieving the loss of a child because it was of a death.
You're talking about empathy. We need to be more empathetic when we talk to people who may be dealing with a mental illness to help stop this stigma, and we will continue this conversation in a bit. Sherry, thank you very much for talking with us. Let's talk about this. If we as a community are going to better provide access not only to crisis care but also intervention services, then we need to also build our sense of tolerance. First responders to mental health emergencies all across Southwest Virginia are learning to become certified in how to effectively resolve situations where someone needs help. We can learn from what they now know, and we better, because we need to get educated too.
Either people can either appreciate it or not.
Mimi Baskin is talking about her son Billy's mental illness. Billy is impacted by behavioral disorders that have forced him to change schools. His mom gets more frustrated each time Billy has problems in the classroom because she says he's seen more as a troublemaker than a child with an illness. She hopes for acceptance and empathy.
The teachers and the professionals have to, because as children, they don't understand and a lot of times, can't identify or be able to recognize that there is something wrong.
I don't think it's the issue of not caring. I think that a lot of people don't know how to respond.
For decades, Diane Kelly has been in the front lines on the battle for awareness. As Executive Director of Mental Health America of Roanoke Valley, part of her day is spent helping those with a mental illness get lasting help.
Okay, now these three scenarios.
She is also teaching mental health first aid. We sat in on a class for Roanoke City Department of Social Services. Before these men and women can communicate the right way with someone who needs their help, they are taught to have genuineness in how they feel and speak.
I guess the first thing I would do is I would try to talk to him while he's at school.
They're also finding out how mental illness affects mood, which affects behaviors. You've been learning some warning signs and some onset signs that you hadn't seen before, known before. What are some of those, and how beneficial do you think it might be to help you?
I think that what I'm learning today is a lot of what signs go together to form a specific mental illness, and what to look out for. So if my kid is not maybe cleaning his house, that's not a sign to look for because that's a normal teenage thing. But if he's not cleaning his house because he lacks energy and then he has other things, we might be looking at a depressive.
I don't care who you are, I want to know why you're here. So your wife called us, she was worried about you and she's worried about... bull crap. You guys are here because my PO called you, right?
The training is also happening for other first responders. Most community services boards team up with their local law enforcement for a week-long course called Crisis Intervention Team, or CIT. If you ever come across an officer, look out for a little pin like this one that will tell you if they've had advanced instruction on how to resolve situations while still showing a person with mental illness respect. Blacksburg Police is striving for a CIT officer on every shift.
Well, our initial goal was to have at least 20% trained in crisis intervention team skills. We surpassed that very early on, and right now our percentage is maintained somewhere around 50 to 60%.
My baby's fine, guys.
But scenarios like the one represented in this training would happen less often, Kelly says, if we acknowledge early on that a mental health issue comes after it noticeably affects your work, your learning in school, or your relationships nearly every day, for more than 2 weeks.
I think we get on the right track by paying attention to early warning signs, to knowing what to look for, and to know that it is important to provide care for people before we reach the standpoint of crisis.
We're joined now by Mimi Baskin, Diane Kelly from Mental Health America of Roanoke Valley, and Gail Burris, the Director of Adult Clinical Services for Blue Ridge Behavioral Health Care, the Community Services Board for the Roanoke area. Diane, I'll start with you. Let's talk warning signs. For adults, obviously, if it's impacting your life for more than 2 weeks, that's when you personally should maybe think about getting treatment. But what are the warning signs that others should look in loved ones?
Mental illness affects behavior, emotions, thinking, and physical issues. So looking for things that are changes, radical changes in those areas are important. Changes in eating or sleeping patterns. Not wanting to participate in activities that have brought pleasure to the person before. Thoughts of hopelessness, helplessness.
Even physical appearance too sometimes.
A physical appearance, expressions of suicide, thinks people would be better off if I weren't here. All those kinds of things are warning signs.
It's a little bit different for children. Mimi, what were some of the symptoms that came with some of the children in your family that you realized that there may be something to it?
Some of the signs that I didn't realize at the time were warnings. My children didn't really care to have social activity or involvement with other kids. I noticed that they weren't really able to make eye contact. There was some aggression.
Things that you look back on now and think, oh, now I see it. Yeah, and it's all about that early intervention and being able to start the process. Gail, let me ask you this though: when someone does get into the process, sometimes mental illness will rob you of the motivation that you need to continue on with the treatment. It's just one of the parts of the disease. So how difficult and challenging is it for somebody who's trying to provide treatment to make sure that there is the proper follow through?
That indeed can be a challenge for mental and other illnesses also. Certainly a lot of people with illnesses of all stripes and varieties may not understand the need for follow-up care and the continuing and continuity of care. I think one of the things that's most important to do is to have very candid conversations with the person who is exhibiting symptoms, very non-judgmental, non-stigmatizing, non-shaming, non-condemning, and instead to be very encouraging, give information, be very descriptive. You know, this kind of behavior causes concern for you because, and explain that. Very individualized to that person. But always very, very thoughtful to be motivating, encouraging, caring, and definitely non-shaming.
And here's another way we might reduce stigma and get more people to seek care. Most mental health patients have been put on 9, 10, even a dozen or more medications to treat their symptoms. What if we could unlock the mystery of our brain and find a way to get a better diagnosis, a better understanding, and a better treatment? The answer may lie in neuroscience, and some of the leading research is happening in Roanoke at the Virginia Tech Carilion Research Institute.
How we approach illness, how we try to understand the illness, but along the way, how we take care of an illness.
On every Thursday this March, doctors and students gathered on the 3rd floor of the Virginia Tech Carilion Research Institute. One night, visiting neurologist Dr. Helen Mayberg shows off results of her research that she may have found the part of the brain responsible for major depression.
Why was it relieving motor symptoms?
Brodmann area 25 is in our cerebral cortex, and Mayberg explains this area is like a transformer in a neighborhood, trying to activate the parts in our brain that affect mood and then our behaviors.
It's a system where when some lines are out, the transformer tries to be smart to send the signal around another way, and that causes a problem in its own right.
She says she has a treatment called deep brain stimulation. A wire placed across area 25 is tuned to a certain frequency that gets the transformer, that tiny area in our brain, to calm down. Her patients feel like a weight has been lifted. The tension is gone, allowing them to achieve what others might consider routine, washing dishes or cleaning the garage.
One of the best comments that one of our profoundly successful patients has said back at work, a youngish woman in her 30s, said, I always thought when I was depressed, people would always ask me to rate my mood 0 to 10. It's taken me a year with the stimulator to realize that that's the wrong question. The scale is -10 to +10 And my goal is to spend most of my time at zero.
In a corner office at the Research Institute, Dr. Warren Bickle is exercising his legs on a desk treadmill. But as the director of the Addiction Recovery Research Center, he's investigating if the brains of addicts can be trained to better cope with intense cravings.
We think one of the most important variables is how people can value the future. Can they have future plans and work to them, or are they stuck in the immediate moment and unable to delay gratification?
Bickle asked his research participants to predict their future. For someone without an addiction, they'd look nearly 5 years into the future. For heroin addicts, just 9 days. Mental illness and addiction often go hand in hand. They're called co-occurring disorders. And just as mental illness needs to be treated long-term, Bickle says addiction is the same, and treatment cannot stop after rehab.
I think we need to recognize that addiction is a chronically relapsing disorder, and therefore it needs treatment that is enduring.
The treatment going on here is as simple as playing games on a computer, training the brain to have a better working memory. So you aren't just searching to satisfy the addiction.
Problem drinkers, and they just had them do working memory training, right, in a person control group, and it suppressed how much they drank.
Those of us who are neuroscientists and are doing brain research like to start off by having a very open mind about trying to understand what causes these disorders and not attribute causality to the person's choice.
Amazing to think of the research that's being done right here in Roanoke to possibly reduce the stigma. Maybe if we can have a scientific connotation with this, we can open up treatment to more people. People will have a better understanding. So if they were going to be engaging in a conversation with somebody who might be approaching crisis, somebody who might be impacted by mental illness, Dan, there's an acronym that we want to use that can give you some guidance on how to have effective communication, and the acronym is ALGE. Tell us what ALGE represents.
Well, ALGE is actually a part of the mental health first aid model that's used by the National Council on Behavioral Health Care. A stands for assess for risk of suicide or harm. L, listen non-judgmentally. G, give reassurance and information. The first E, encourage appropriate professional help. And the second E is encourage self-help and other support strategies.
So let me ask you, Mimi, let me ask you, Sherry, which ones of those has it been most difficult for you to get from community members?
Listening non-judgmentally.
Yeah. What do they want? What do they want to do? Do they want to affix labels? Is that the issue?
Even in an attempt to try to be professional, a lot of the professionals, I think, just, there's this way of dealing with, these mental health issues that I think people have become so accustomed to because of the stigma, we just haven't. We need a breakthrough. We need to get beyond that. And
you were telling me, Diane, that mental illness is the no casserole impairment. Tell me about that.
When people experience other kinds of health crises, broken hip, having a new baby, having a heart attack, they come back into the community. We want to meet their needs. Take food, go visit, help with household chores. People with mental illnesses need the very same things to be cared for.
So should you bring them chicken soup if they're feeling ill?
Of course. And you should stay with them while they eat.
Thank you very much. Please go ahead.
That was the piece of encouragement for the families, encouragement for the person that is suffering with mental illness. And with the stigma, so many people do not know what to do or what to say, and they do not get the casseroles. It's more of, let's back away from the actual issue of what's actually going on.
It's a simple attitude change, but of course, as we all know, that attitude change is not so simple. Thank you very much, all of you, for coming and talking about this issue that we are trying to reduce the stigma for. I volunteered for this assignment because, like many of you out there, my family and I are impacted by mental illness. But my task of reporting on mental health and its treatment is only beginning. There are so many stories yet to be told, and the conversation needs to continue. So let's keep it going on social media by using #StopTheStigma, because I need you to steer me in the right direction, because we are all in this boat, in this ocean together. And whenever possible, show empathy and be genuine in your care. It is always possible. Take care. Good night.